Assalamu alaikum wa rahmatullahi wa barakatuh. Our subject today is about rheumatoid arthritis. Rheumatoid arthritis is symmetrical inflammatory polyarthritis, primarily involve the small joint, characterized by morning stiffness lasting more than 1 hour. In a classical site, there are 7 classical sites: PIP, proximal interphalangeal joint, metacarpophalangeal, MCP, wrist, elbow, knee, ankle, and antibidy joint. Third is synovitis, characterized by soft tissue swelling or fusion, subcutaneous nodule over the bony prominence or extensor surface. Then we have morning stiffness, classical site, synovitis, subcutaneous nodule. We will go to investigations. Rheumatoid factor. If rheumatoid factor is positive, alone not diagnostic enough for rheumatoid arthritis. If rheumatoid factor is negative, also not exclude, because it is sensitive in 80% and specific in 70%. ASR and selective protein non-specific and elevated. CBC will have normocytic anemia. Anti-CCPA is the most important, and when positive its specificity is about 95%. Sensitivity is low, 70%. 70% of patients with rheumatoid arthritis at time of diagnosis have a positive anti-CCPA. X-ray. X-ray is important. We should have baseline X-ray and follow-up X-ray. About 2 years after rheumatoid arthritis, especially those not managed well or not compliant to management, will have erosion. Ultrasonography is more sensitive and good imaging for synovitis and erosion. MRI for subluxation of spinal vertebra. Symmetrical arthritis. Not all symmetrical arthritis are rheumatoid arthritis. When there is skin rash with symmetrical arthritis and leukopenia, think about SLE, not rheumatoid arthritis. When there is psoriasis or pitted nail, think about psoriatic arthritis. In patient with their care worker or contact with small children with symmetrical arthritis, think about parvovirus 19, P19. Also, when there is symmetrical arthritis plus second and third metacarpal joint and proximal interphalangeal arthritis with hook-like osteophyte, think about hemochromatosis, deposition of iron in this joint. When there is symmetrical arthritis and rheumatoid phenomena and sclerodactyly, think about systemic sclerosis. When there is a proximal muscle weakness plus symmetrical arthritis, think about polymyositis or dermatomyositis. Well, when there is recent immunization and symmetrical arthritis after that immunization, think about rubella immunization arthritis, post rubella immunization arthritis. When there is symmetrical arthritis and tophi plus symmetrical joint involvement of hand and feet, there is tophi, typhus disease. It is a chronic typhus gout. Well, what about the extra articular manifestation of rheumatoid arthritis? There is subluxation, C1, C2, increased risk of cord compression with tracheal intubation. Patient present usually with paresthesia. Bronchiolitis obliterans pneumonia, present with fever, cough, dyspnea. Also, the other extra-aortic manifestation, mononeuritis multiplex vasculitis, present with wrist drop or foot drop. Cricoarytenoid involvement, present with hoarseness of voice. Kaplan syndrome, there is a pulmonary nodule. There is basilar pulmonary nodule present. Pneumoconiosis related to occupational dust, characterized by rapid development of multiple basilar nodule and mild airflow obstruction. One of the manifestation of rheumatoid arthritis. Sjogren syndrome, dry eye, dry vagina, dry mouth, we know the Sjogren. Rheumatoid pleuritis, patient with pleural effusion. Rheumatoid interstitial lung disease, we mean pulmonary fibrosis. Okay. Rheumatoid vasculitis with skin ulcer. Felty syndrome, there is splenomegaly and granulopenia. Granulocyte is low. Scleritis and uveitis present with classical symptom of red eye, painful, and red eye. Rheumatoid disease associated cardiac heart failure or anti-TNF therapy associated with heart failure. Also coronary artery disease. Other manifestation not extra-articular, which is osteoporosis. Well, we go to treatment. Treatment include non-steroidal anti-inflammatory and intra-articular glucocorticoid in acute pain joint. DMARD therapy is very important, MTX methotrexate or leflunomide or both combination. These for initial mild disease. Monotherapy involve methotrexate plus either hydroxychloroquine or sulfasalazine. Combination therapy MTX plus hydroxychloroquine and sulfasalazine. The three medication combination is better than monotherapy. Combination therapy is better than monotherapy and more effective. Biological therapy. We go upstairs if patient not get well on this therapy from beginning DMARD therapy, monotherapy, combination therapy. Biological therapy is indicated. Initial therapy is a TNF-alpha inhibitor. We should add these to baseline MTX therapy. Added biological therapy to MTX. These TNF-alpha inhibitor include etanercept, infliximab, adalimumab, zirtelzumab, golimumab. Okay. Note: in biological therapy should screen for latent TB before start biological therapy because of the risk of reactivation of TB. Surgery. Surgery reserved for ruptured tendon repair. One of the complications, intractable pain, severe functional disability. There is other measure in treatment. Smoking should be stopped. Vitamin D, calcium supplement for all patients. Bisphosphonate for osteoporosis. If occur. Vaccination for pneumococcal and influenza vaccine should be. DEXA scan also should be for osteoporosis, cardiac evaluation. In pregnancy, we can choose hydroxychloroquine and sulfasalazine is safe during pregnancy, but MTX and leflunomide, this medication, are absolutely contraindicated in pregnancy and should stop before pregnancy.